So that's me, Rob Wynn. I'm a pediatric hematologist. I am a bone marrow transplanter, and I'm going to talk about Hunter syndrome, which is an example of a lysosomal storage disease, an MPS disease. I'm going to talk about similar diseases. So this is my first summary, is why does blood stem cell transplant correct a lysosomal storage disease? What are our lessons from allografting? And the lessons from allografting are to transplant early if you want to do well, and that the allo has an enzyme dose effect. And so this is the medicine of improvement. So when I talk about autologous stem cell gene therapy approaches, it's what we've learned from allogeneic transplant. And I'm going to talk about MPS II and MPS III. I'm then also going to talk about what there's been a theme of this conference, which is bringing our medicines to the kids who need it and overcoming those barriers. I'm going to talk about MPS IIIA, that we've been going at a long time, good results, nice paper, but we haven't treated the patients for many years. And MPS II, which I'm going to talk about now, and which is funded by LIFOC, is also completing its proof of concept. And so as well as the language of medical improvement, I'm going to be talking this language, as so many others, of unmet need. So this is cross-correction. So hematologic cells derived from a donor during transplant give the enzyme. So it's not so intuitive that transplant will correct an enzyme deficiency. If there's a disease of the blood, you can see why engrafted donor healthy marrow corrects the disease. But in an enzyme deficiency, the engrafted donor leukocytes make and deliver the deficient enzyme, both in the somatic system here, but also into the brain, because our leukocytes cross the blood-brain barrier, in contrast to many of our drugs. And this is what happens before the transplant. The kid has no enzyme in red, but then donor-derived leukocytes deliver enzyme. And before the transplant, the substrate of the enzyme is accumulated, and after the transplant, the enzyme delivered by engrafted donor leukocytes catabolize accumulated substrate, which is the beginning of the disease. This is my medicine. So you can see that this is one of these lysosomal storage diseases. And you can see that untransplanted kids do not outlive childhood. So almost all children are dead by the age of 10. You can see that transplanted kids have a flattened curve, and so we prevent the early mortality associated with the disease with transplant. But you can also see that after transplant, in a previous era, you are more likely to be dead if you've had a transplant than if you haven't, and that is toxicity associated with transplant. In my Lancet paper there, I'm saying that BMT is the most likely way of being alive in 3 decades, but it's also the most likely way of being dead in 3 weeks. And so how have we improved outcomes? Because these curves are now different. So transplant outcomes are vastly better. So for that metabolic disease, we would be reporting outcomes of 95% now survival, better with better supportive care, but actually better with better donors. So those of you that are on donor registries are contributing to these outcomes. But transplant is not just about surviving the transplant, it's about correcting disease. And what we've learned about these lysosomal storage diseases is that we have 2 factors that determine the outcome of the child in terms of their disease. First of all, is the age at transplant. So young kids do better. Transplant is better at preventing disease progression than it is about reversing established disease. And enzyme dose. So we published this in 2009, and here we see the metabolic outcome, so the residual substrate in kids that have had an unrelated donor transplant, a wild-type transplant with 2 gene copies, which is much better than the kids that have had a carrier donor, and much better than kids that have had pharmacologic enzyme replacement. So the nice thing about my work is that in this field is that the competitor treatment is very expensive and relatively poor compared to transplant and cell-delivered therapies. But of course, I can't deliver more treatment than what a wild-type donor can do with allogeneic transplant. It is important also to say that this is not just metabolic outcome, so these kids do better clinically, better disease outcome, better quality of life than these kids. And so we come to MPS II Hunter syndrome, which is another lysosomal storage disease, which is refractory really to transplant. So I've talked about a responding disease where we have a sensitivity to the enzyme dose. So the transplant delivers enough enzyme to correct MPS I, which is what I've shown you. Here we have MPS II, which however much early you do the transplant, the graft, the donor-derived leukocytes do not give enough enzyme. So not only is transplant toxic, it is ineffective. And so, but we go from the same hypothesis, which is there an enzyme dose effect. And if a wild-type donor is not enough, does not deliver enough enzyme to correct a disease, our hypothesis was that we could use an autologous approach and re-regulate gene expression so that it delivers more enzyme. And so here is our vector. So what we're doing is we're taking the kid, we are leukapheresing them, so we're taking their hematopoietic stem cells, and then we are transducing them with a lentiviral vector, and then doing a bone marrow transplant still, but this time using gene-modified autologous cells, and here's the vector that we're using. And so this is a standard lentiviral vector. So here's the enzyme gene. So this incorporates, of course, into the hematopoietic stem cells so that the progeny have the enzyme gene. But here we have given a promoter next to the gene. This is a myeloid promoter. So this is a CD11b promoter. So CD11b is a neutrophil or a monocytic protein that all of you have. And the 11b promoter will drive expression of the 11b protein gene in your myeloid cells. So by putting the 11b promoter next to the enzyme gene, we are trying to drive enzyme expression in the transduced cells so that we can have supraphysiologic enzyme, because physiologic enzyme does not correct the disease. We've also added an ApoE2 tag here. So that allows enzyme made in the bloodstream to translocate across the blood-brain barrier because through this ApoE2 tag, because we engraft the brain immediately after the blood immediately after transplant, but the brain takes many months, and so we want to get enzyme into the brain translocated from the blood very early. So easy study, taken autologous hematopoietic stem cells in kids with Hunter syndrome with this human IDS a lentiviral vector under the control of a CD11b promoter. So the aim was to recruit 5 patients, and this is what we've done. We have identified kids with severe Hunter syndrome because they have a deletion, so no enzyme, or they have a family history where their brother, this is an X-linked disease, has already died with neurologic manifestations. So we've taken severe MPS II. There are milder forms with some residual enzyme, but it's never mild. We leukapherese them, and this is a challenge. This is a rapidly progressive neurologic disease, and we want to get to the kids early. And getting to the kids early means leukapheresing kids who are only 5 kilos, and then we manufacture, and then we transplant. So we give chemotherapy, and we give back the gene-modified autologous hematopoietic stem cells. Mainly a safety study, a biochemical efficacy study, and then to see what it does to the kids. We've treated 5 kids, none from the UK, actually all from abroad, one from the US, which was the poster kid that you may have seen on the news, a couple from France, one from Croatia, and one from Australia. So what, in leukapheresis, we mobilize hematopoietic stem cells into the blood, of course. We take these hematopoietic stem cells and transduce them, and then this is the transplant. So just to see that we get rid of the patient's own bone marrow, this generates still some risk, but much less than an allo. This is neutrophils, this is platelets, and then we have engrafted gene-modified cells. And remember, what we want to see is supraphysiologic enzyme, because physiologic enzyme, a wild-type transplant, does not correct disease. So here we see leukocyte enzyme activity. This is the normal range. It's in green at the bottom, and you can't see it. So it's about 10. And here we have 100 to 1,000-fold overexpression of the transgene protein in engrafted hematologic cells. It's in the leukocytes, and it's in the plasma. And because this is a myeloid protein, a myeloid promoter, we're seeing it mainly in the myeloid cells. We're seeing it in the bone marrow. It's a brain disease, and we see enzyme very early after transplant into the brain. And not only is there enzyme there, but it is catabolizing accumulated substrates in all compartments and very early after transplant. So we have achieved what we want to achieve. We've got a safe transplant, we've engrafted genetically modified autologous hematopoietic stem cells, and we have supraphysiologic deficient enzyme driven by the CD11b myeloid promoter. There isn't much of an immune response against it, which is interesting here, although that has been described in some patients, and we've added some immune suppression. So this IMP is safe and effective, rapid engraftment. We get massive supraphysiologic enzyme without toxicity, and we get it in the brain. So MPSIII. So this is another transplant refractory lysosomal storage disease. And again, we've done allo transplant in this disease. It's a neurologic disease. It's a devastating disease. Your kids will develop normally for 2 or 3 years. They will plateau, and then they will regress. And they will have a long regressing neurologic illness, which associated with premature death, usually in the teens. They have a horrible excitation phase, and if you've ever had a 3A child in your clinic, you would know about it. They destroy the clinic around you, and it's destructive for children and for families, and there is no treatment. But it's in the same pathway as transplant-sensitive diseases. So again, we have formulated many years ago the hypothesis that if we can deliver supraphysiologic enzyme, we will correct an otherwise refractory lysosomal storage disease. Here's the normal range. Again, we've got 100 to 1,000-fold enzyme overexpression of the transgene protein. This time it's an enzyme called SGSH in the 5 children that we've transplanted. Again, none from the UK, all from abroad. And what we see here is catabolize of accumulated substrate. But we do not look after children so that they survive transplant. We do not look after children so that their enzyme level looks nice or that their substrate levels are normal. This is why we look after children. So you can see the natural history of this disease in the gray is that kids develop normally. This is the normal range. And then they plateau, and then they regress. This is the devastating disease that is Sanfilippo, MPSIII. But you can see of the 5 kids that we've transplanted, all with severe disease, with siblings affected, or with deletional mutations, 4 of those kids are developing normally with normal neurologic development now, many years after transplant. And so this means that your children with this disease are developing continence, or talking, or singing, or walking. And so, you know, this little green one here, she's in my clinic the other day. She was singing to me and talking to me. She sings in German, so I'm not quite sure what she's singing. But you can see the difference we're making to the natural history of the disease. And I come to the final point then about these diseases, these lysosomal untreatable diseases. The traditional pathway, preclinical work, and we did this a long time ago with an animal model, a proof of concept study, which is what I've shown you, and then a licensing study and the need for commissioning up to this point through commercialization. But we haven't treated the kids for a long time. And, you know, are there different ways? And there's been many things here talked about how we can accelerate the kids' treatment platform approaches, no animal model in the preclinical, academic vector manufacturing, early regulatory involvement of course, and early commissioning involvement. Because in my conclusion here, I've not treated a kid with MPSIII for more than 3 years. I get many emails a day, a week from families with these diseases who know that I have a treatment because they've read the fancy papers, but I have not got access to the treatment for them. I do believe that as a community, and not without the best will in the world, we're failing patients and families, and actually they funded our work in the beginning. I've shown you the medicine of improvement. What I do in autologous stem cell gene therapy is what we have learned over 30 years from allogeneic. We have learned the lessons of how to make the transplant safer and the lessons of how to make it more effective. This is good science. It's good, not as good as other people's science at this meeting, I'm going to say, but good for reputation, good for the UK, and it's cost effective because otherwise these kids are either dying or they're having very expensive enzyme replacement. Together, and that's what this conference has been so inspiring. Together we must make this work, and we must both do the medicine of improvement, and we must listen to the language of unmet need. And I'm going to thank my team, and thank you.